بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. طلابنا الأعزاء، نبدأ محاضرة Pelvic Organ Prolapse. بداية objectives of this lecture. By the end of this lecture, the students should be able to define the genital prolapse, summarize the types and the grades of a prolapse, differentiate between its types by history, and demonstrate on the Millikan the examination of a case of a prolapse, and predict the management option for different case presentations. To start with definition, pelvic organ prolapse is the downward displacement of the pelvic organs from their original position into or beyond the vagina. يعني أي عضو يكون خارج الحدود الطبيعية يعتبر prolapse. The classification of a prolapse, we classify the prolapse according to the sides. We have anterior, middle, and posterior compartment. And according to the organs involved, we have the bladder, cystocele, the upper 2/3, the urethra, urethrocoele, the lower 1/3, the uterus, uterine descent, and the vault prolapse, vault اللي هي vaginal vault, and the posterior compartment, the upper 1/3, the enterocele. Enterocele, it means the small bowel. And the lower 2/3 is the rectocele, which means the rectum. So according to the site and according to the organs involved. Here you see this is anterior compartment. This is the bladder, the upper 2/3. So this is a case of cystocele. It is the bladder descent. Here the anterior compartment, but it is the urethra which is involved. The lower 1/3, this is the urethrocoele. Again, a cystocele, and here urethrocoele. And there could be cysto-urethrocoele. يعني اثنيناتهم سوية, both anterior wall compartment. The posterior wall, we have either the rectum here, it is the rectocele, which is the lower 2/3, and the small bowel prolapse here in the upper 1/3, this is enterocele. Here we have the enterocele, and here we have, this is the rectocele. Again, we can have both upper and lower posterior wall prolapse. The uterine descent, you see here the uterus supported in place by the ligaments and fascia. Once there is a damage, there will be descent of the uterus downward. This is the uterine descent. Here the uterus in normal position above the bladder, and here it is descended downward into the introitus, and here it is passing the introitus to the outside. So this is a uterine descent. Grading of descents, we have 3 grades for the prolapse of the uterus. Grade 1, the first degree prolapse, when the lowermost portion is within the vagina. Here you see it is a prolapse, but it is still within the vagina. Second degree prolapse, when the lowermost part reaching the introitus here, reaching the introitus. Once this prolapse beyond the introitus, this is called a procedentia, which is the 3rd degree prolapse. Usually, the uterine prolapse is associated with vaginal wall prolapse. So you see, for this patient, she has cysto-urethrocoele and rectocele. Here, the grades, this is in normal position, and here the uterine descent, and here the procedentia. Normal variation, this is the normal side of the uterus. It is an anteverted coming forward. 15% of the normal women having a retroverted uterus, the uterus going backward like in this picture. The pathophysiology, why prolapse happened, there is damage to the supporting tissue of the uterus and the vagina. The supporting tissue here, the ligaments and fascia, the levator ani muscles, which keeps the pelvic organ in place, and the posterior angulation of the vagina. You see here, these are the ligaments and fascia. The most important one is the transverse cervical ligament here. This is the most powerful ligament connecting the cervix to the pelvic side wall. This is the transverse cervical ligament. Another name is the macroid ligament or the cardinal ligament. So this is the most important one. Other fascia and ligaments also plays a role. The other mechanism is the posterior angulation of the vagina. You see here the vagina going backward and downward. So when there is pressure from above here, the uterus will be compressed and this will act like a valve. مثل فتح صمام يمنع prolapse of the uterus. So this angulation will prevent the downward displacement of the uterus. Here another picture for the supporting tissue. This is the urogenital diaphragm, the lower support. This is the levator ani muscles, okay? And here the transverse cervical ligament or the cardinal ligament from the cervix to the pelvic side wall. The etiology, why prolapse happened? We have congenital cases. Here there's congenital weakness in the supporting tissue. Childbirth and raised intra-abdominal pressure, this is the most important cause because with vaginal delivery, there is a trauma to the pelvic soft tissues. Chronic cough and constipation will increase the intra-abdominal pressure and will lead to prolapse. Aging and menopause, because once estrogen becomes deficient, the estrogen is required for the integrity of soft tissue of the pelvis. Post-operative, after we do hysterectomy, we should suture the vaginal vault to the ligament, to the transverse cervical ligament. So once we don't do that, there will be a vault prolapse and obesity and smoking. The diagnosis, by history, women usually present with non-specific symptoms. So by history, we should evaluate the symptoms and evaluate the risk factors. For example, highly porous women, history of operative delivery, مثل مسوي لها forceps delivery, chronic cough, constipation, these are risk factors for prolapse. Non-specific symptoms, lump in the introitus, local discomfort and backache typically increase towards the end of the day. تقعد المريضة الصبح تقول ما عندها أي مشكلة. بعدين وهي ما تشتغل تتحرك down, the patient will develop local discomfort and clump in the introitus will increase in size. This is typical of a prolapse. Bleeding, infection, if ulcerated, if there is a prolapse beyond the introitus, there will be friction, so there may be bleeding and infection. Dyspareunia or apareunia with cases of severe prolapse. In extreme severe cystourethrosis, uterovaginal or vault prolapse, there will be renal failure from ureteric kinking. It's a kink biliureter, so backward pressure on the blood, on the kidneys. Specific symptoms, this will depend on the type of a prolapse. Cystourethrosis usually present with urinary frequency, urgency. There may be voiding difficulties because of the bulge into the vagina, so there will be incomplete emptying. And because of this incomplete emptying, there may be urinary tract infection due to stasis of urine. And the patient may develop stress incontinence because of the weak sphincter mechanism due to prolapse and anatomical distortion of the normal side. Rectocele, incomplete bowel emptying, digitation and splinting. In this case, the patient needs to put her finger digital support on the perineum in order to defecate. This is digitations and splinting, and there may be anal incontinence. Examination, abdominal examination for masses, hernias, and scars. Vaginal examination, prolapse may be obvious when the patient in the dorsal position. dorsal position المريضة نايمة على ظهرها على السرير and the legs are flexed, and we see if there is any mass protrude beyond the introitus. Again, if there is any mass protrude, we should look for any ulceration or atrophy. This is called the decubitus ulcer. The anterior and posterior vaginal wall and the cervical descent should be assessed with the patient's training. أسأل المريضة تدفع أو basal maneuver with straining نستخدم السيمز speculum. This is the Sims speculum, and here the Sims position flexion of the upper thigh. We can use it for examination of a prolapse, incontinence, fistula, because it allows an inspection of the vaginal wall. Again, by examination, assess the uterus and the cervix for any mass. There may be a mass pressing on the uterus. Pelvic floor tone assessment. I examine the patient, and with PV examination, ask her to contract her pelvic floor muscles. Pelvic floor muscles بالضبط هي المسلز اللي تمنع passing urine. يعني أقول المريضة once you pass urine, stop this or prevent passing flatus. These are the levator ani muscles. So I assess the tone and the strength of contraction of these muscles. Cuff test for stress incontinence. Ask the patient to cuff and inspect the urethra for any leakage of urine. The patient should have a full bladder. If the urine leaks, this is stress incontinence positive. Decubitus ulcer, you see here, this is the procedentia, friction here, so this is an ulcerated skin. The treatment, we reduce the prolapse into its normal area. We put local estrogen and packing. This will help in healing in this ulcer. Antibiotics may be used. Investigations. For any case of prolapse, the diagnosis is a clinical from history and by examination. Sometimes we send investigation to exclude, for example, urinary tract infection. We send for general urine exam, urine flow studies, and measurement of urinary residual volume. Urodynamic can be done for cases of cystosis. If there is severe prolapse and renal failure is suspected, urea and creatinine to be sent and renal ultrasound. For cases of rectocele, we can do radiological investigations, dynamic magnetic resonance imaging, and transperitoneal ultrasound. Prevention of prolapse. How you prevent the prolapse? Prevention is by limiting the injury to the pelvic support during childbirth. احنا قلنا the most important cause in our community is the childbirth, and especially frequent childbirth without the proper interval which allows healing of the trauma to the tissue. Okay, so prevention: avoid prolonged labor, avoid bearing down before full dilatation. لازم اتاكد المريضه تصير fully dilated cervix, and in the active phase of the second stage, يعني head descended into the pelvic floor, يلا احطها in levotomy position and ask her to bear down. Avoid difficult instrumental delivery. إذا الهيد عالي وممكن الانسترومنتال birth يسوي لها trauma, deliver by cesarean section is better. Encouragement postnatal pelvic floor exercise. ورا ما تجيب المريضة علمها على الكيجل exercise, how to do it to enhance the tone of the levator ani muscles. Family planning. لازم عندها inter-pregnancy interval of at least 2 years. سنتين بين الولادة والحمل الثاني. هذا الوقت ضروري to allow healing of the tissue that get injured during vaginal delivery. Avoid and treat factors which increase the intra-abdominal pressure, such as obesity, chronic cough, constipation, and smoking. And these simple measures may play a role and may improve the condition significantly. Prevention of postmenopausal atrophy. Although the evidence to support this is minimal, we ask patients to take a balanced diet that contains estrogen, exercise, calcium, and the use of hormone replacement therapy. These may play a role in the prevention of prolapse. The treatment: always mention the general measures in the start. The patient may be obese, she has a chronic cough, constipation. The treatment of these two problems may resolve the problem. If the prolapse is ulcerated, 7 days course of topical estrogen can be given, which allow healing of the prolapse. After correction of these general measures, because even if we treat the condition with persistence of these general problems or complaints, the condition may recur, okay? So first, general measures. Second is the conservative measures. Pelvic floor physiotherapy, we call it the Kegel exercise. In cases of mild prolapse, we ask the patient to contract her pelvic floor muscles. First, locate the pelvic floor muscles. These are the muscles which prevent passing urine and flatus. Ask the patient to squeeze it frequently to start with for a short time, for a few seconds. Relax for a few seconds, 10 seconds, and then repeat gradually. Increase the frequency, just like any muscle building. Gradual increase in the frequency. This will help to increase the strength of the muscles. Avoid very frequent exercise because this will cause fatigue in the muscles. Vaginal rings, these are rings placed around the cervix in the same way as contraceptive diaphragm, and these need replacement at annual intervals. And we have the ring pessary and the shelf pessary. Here the ring pessary, the cervix will be here, so this will support the uterus in place. And here the shelf pessary, in case of failure of ring pessary, or if the patient is sexually inactive, we can put this shelf pessary. Here, this is the ring pessary. This is the place around the cervix here, so this will return itself above. In case of failure, we can give the shelf pessary like that. This will occlude the prolapse here and will prevent the descent of the uterus. Indications of conservative treatment and pessary treatment: when the patient not wants surgery, can be done as a therapeutic test. When the childbirth is not complete, put in mind that if you do surgery for the patient and get pregnant again and deliver again, the condition will recur. And at such time, the treatment will be difficult. So once the patient is young, not completing her family, we put for her ring. And then after completing the childbirth, we can do the definite surgery. If the patient is medically unfit and the surgery is very risky, during and after pregnancy, the patient is pregnant, so we put a ring, and then after the uterus become big in size, retained within the abdomen, we remove the ring. And after delivery, we wait until the end of the perineum. While awaiting surgery, in case of long waiting list, we can put ring, and then after that, with a suitable time, we do the surgery. Complications with pessary: there may be pessary ulcers or abrasion because the pessary is of big size. So here we remove the pessary, we put local lubricants, sometimes antibiotic, and this after healing, we reinsert the suitable pessary. So first we have general measures, then we spoke about the conservative measures, and the last thing is the surgery. The choice of surgery depends on the type of a prolapse, the age and the parity of the patient, this is very important, and the coital function. For the cystourethrosil, we have anterior repair or anterior colpo. Colpo, it means vaginal vault. Raphe, it is the suturing, so anterior colpo, raphe. You see here, this is the bulge of the vaginal mucosa. We incise the vaginal mucosa. We suture the supporting weak tissue, like in this picture, incision of the vaginal skin. This is the weak supporting tissue, and here the bulge of the bladder. We suture it, and then we excise the extra skin, and then we suture it. Here you see this is the reduced prolapse. This is the anterior colporaphy. For the rectocele, we have posterior colporaphy, the same idea. We incise the vaginal skin. We repair the loose supporting tissue here by suturing. And then the extra skin, we excise it by trimming. الجوز هذا السكين الزايد, and then we suture it. Enterocele, the same idea. We incise the vaginal skin, we suture the loose tissue, and then we excise the extra skin and suture it. Surgery for uterovaginal prolapse. When you have uterine prolapse, usually it is associated with vaginal wall prolapse. The uterine preserving surgery. Here the patient needs to keep her uterus, and because further children is required and because she is young. The operation is the hysterosacropexy. Hystero means the uterus, sacro to the sacrum, pexy is the fixation. You see, we fix, this is a synthetic mesh that can be sutured to the cervix here and to the anterior longitudinal ligament in front of the sacrum here. And this is the hysterosacropexy. This can be done by abdominal route or by laparoscopic route. The other operation is the Manchester repair. Manchester repair, when the patient having a long cervix, we amputate the cervix. Okay, نقلل طول الcervix because of its abnormal length, it protrudes beyond the introitus. And then we suture the uterosacral and the cardinal ligament in front of the cervix. This will help to elevate and support the uterus in place. The Lefort colpoclasis, this operation is useful for a very frail patient, مريضة old age, unfit for surgery. We incise the anterior and posterior vaginal wall after reducing the prolapse, and then we suture the anterior to the posterior wall. So we obliterate the vagina. هنا نسد الفاجينا after reducing the uterus, and this is useful for patient who is old age and unfit for surgery. Here, this is the synthetic mesh that we use it, okay, in the hysteropexy. Procedure involving hysterectomy. Vaginal hysterectomy is the definite surgery and involve hysterectomy through the vagina. We incise the vaginal mucosa, we clamp and incise the pedicles, and then we close the vaginal mucosa. Here, this is the vaginal hysterectomy. If the patient having anterior and posterior vaginal wall also, we can do anterior and posterior colpography. Total abdominal hysterectomy and sacrocolpopexy. After we do total hysterectomy, we fix the vaginal fornix to the sacrum. So after that, we do sacrocolpopexy by mesh. Subtotal abdominal hysterectomy, we remove the body of the uterus and we keep the cervix, and then we do sacrocervicopexy. We suture the cervix to the sacrum, sacrocervicopexy. Vault prolapse. After hysterectomy, the vault may get prolapsed, and in this operation, we do sacrocolpopexy. Here, this is the sacrum. Okay, we use a synthetic mesh that is sutured to the vaginal vault, sacrocolpopexy. This is for vault prolapse. Another operation for vault prolapse is the sacrospinous ligament fixation. In this case, we incise the vagina here, and then we suture it. This is a vaginal approach, so we prefer it أفضل من العملية السابقة اللي هي abdominal approach. طبعا complications أقل إذا نستخدم الvaginal approach. We suture this vaginal vault to the sacrospinous ligament here, okay? Sacrospinous ligament fixation by a non-absorbable suture, so the vagina will be returned upward. This flow chart illustrates a summary of the treatment that we have mentioned. Thank you so much.